We want to welcome you to our webinar. We just have a few minutes before we get started. So if you're able to join us, we've got some instructions around some tips and tricks around listening if you're having any trouble with the audio. We're going to get started in just a moment. We are almost at the top of the hour. Just waiting till we hit 1 o'clock before we launch the full webinar. As you can see on your screen, we have some tips around audio, and just wanted to extend an invitation to any of our attendees to type in the chat where you might be from. Hi, I'm coming to you all today from Virginia. I'm in Lynchburg, Virginia, and we've got some our panelists are from a couple different locations. You see Pittsburgh, Bend, Oregon. We've got Lancaster. Any others? Ah, I see Shanna's from Sunnyvale. Hi, Shanna. All right, and we're as far reaching as Mexico.
Wow.
All right, I see it's 2 o'clock and I want to honor and respect our time. So as people are joining, again, we welcome you to pop into our chat and let us know where you're coming from. I again mentioned that we've got some information on the screen about audio, so feel free to check your settings if you're having any trouble. And with that, we have our Periop webinar that we want to kick off. So a couple logistics to think about. This is going to be a panel discussion, and it is a live webinar. So we're requesting that anyone in our audience use the chat feature or the Q&A function within Zoom to type any of your questions. We will be muting the line just to help manage a little bit with the audio and the noise level, so we can control that a little bit for just an optimum experience for everyone. But we will be actively managing the chat and the Q&A. There is going to be a recording of this webinar sent out if you've registered, and so you'll be able to go back and take a look at any information that you might have missed, and or repeat any sort of conversation that might be interesting to you. So we welcome you to stay tuned for that. All right, at this point, what I'd like to do is just kick off and introduce our topic as well as our panelist. So today, this afternoon, it might be morning for you, depending on which time zone you're joining from. We have the Value Capture team is hosting a webinar around breaking the cycle, so creating lasting change in perioperative care. We are very excited to facilitate this conversation. I know this topic resonates with so many of you in the healthcare community. And we struggle with sustainable improvement and long-term lasting change. And it's difficult in any environment that we experience change or performance improvement in. But today we're really going to hone in and we're going to focus on why this feels especially challenging when we talk about perioperative services. And our panelists are going to be able to share with us some of the things that they've done in their work or are planning to do differently based on what they've learned as they think about designing around sustainable change. So I'm going to provide just a quick introduction. So I am Allison Hartman, Senior Advisor with Value Capture. I have over 25 years of experience working in healthcare, performance improvement, quality, patient safety. I've worked in both hospitals and health systems, and I've spent many, many hours and weeks and time with surgical services leaders, physicians, and staff, helping them improve the care they provide to their patients, both independently and within the broader system of healthcare. It's a real honor for me to be here today with our participants and to moderate our webinar. Before we get to our panelists, I do just want to mention briefly Value Capture and introduce the company to you for those of you that might not be familiar. We are a trusted advisory firm. We work across the continuum of healthcare, and we're here to help you solve your biggest problems, but thinking about the long term in mind. So we're going to partner with you to create solutions with the stance of no trade-offs. We're leading to exceptional change, and most importantly, leaving you and creating that knowledge to continue to improve. We strive to help clients produce perfect health with zero harm, weight, or waste, both for our patients and our team members, all with the community in mind. And so with that said, let me introduce our panel. And you can see on our screen, we've got some faces here that are going to be joining us today. And I want you to know that you'll have some contact information also provided in the slide as well for each one of them, should you want to reach out after. So our first panelist is Amy Kosick. Amy is a master's prepared nurse. She's certified in infection prevention with over a decade of nursing experience. Since 2016, Amy has specialized in infection prevention and hospital epidemiology. Amy is serving as the manager of infection prevention at Penn Medicine's Lancaster General Health System for the past 3 years. Through that time, she's been leading initiatives to enhance infection control practice and improve patient outcomes. Throughout her career, Amy has worked closely with perioperative departments, fostering strong partnerships with surgical teams and sterile processing departments to ensure compliance with best practices in sterilization, disinfection, and infection prevention. Her expertise in developing and implementing evidence-based protocols has contributed to improved healthcare quality and safety for the Lancaster community. Welcome, Amy. We're thrilled to have you with us today. Thank you, Amy. Our next panelist is Dr. Dan Bissell. Dr. Bissell is a board-certified emergency medicine physician and the chief medical officer at Legacy Good Samaritan Medical Center. With over 20 years of frontline experience in emergency medicine, Dan has led leadership positions such as the president and CEO of Northwest Acute Care Specialist, which is an independent medical practice of over 150 providers in 8 locations. He served as on the medical executive committee at Legacy Salmon Creek Medical Center and was the co-founder and CEO of Innovo Alliance, which is a healthcare informatics startup. As part of Dan's commitment to community outreach, he's also the co-founder and board member of the Portland Street Medicine, a nonprofit providing direct care to the homeless in the Portland metro area. He's a deep systems thinker that has passion for improving care delivery, using systems design and technology to find innovative solutions and to enhance the role of the electronic health record in clinical practice. In his role as Chief Medical Officer, Dan is also the executive leader for the Inpatient Throughput Care Initiative, as well as the Surgical and Interventional Service Value Stream Work Team. Welcome, Dan.
We're great to be with you
today. And then our third panelist is Sean McBride. Sean is the Associate Director of Clinical Operations for Penn Medicine's Interventional Support Center. The ISC, as they lovingly call it, services multiple academic and community hospitals located in the greater Philadelphia metro area. The ISC is one of only a handful of freestanding centralized centers in the country providing sterile processing, supply management, and case cart delivery to support hospital operating and procedural rooms. Sean received his bachelor's in nursing from Thomas Jefferson University and an MBA from Villanova University. He has over 12 years of experience working in the perioperative environment as an operating room nurse and clinical OR coordinator, as well as clinical informatics specialist. Sean brings a deep understanding of the perioperative workflow and a customer-oriented approach that has created trusted relationships across the entities that the ISC serves. His collaborative leadership approach and willingness to test new ideas has resulted in a transformation in the daily operations of the ISC. Welcome, Sean.
Thanks for having me.
All right, so we're very excited to have you all with us today, and let's jump right in. So again, our focus here is around sustainability of change, which we know affects all aspects of what we do. And so not, again, unique to just the perioperative space, but that's where we really want to spend our time and focus. And so I'm interested to hear from each of you, really, what unique challenges with sustainability have you encountered in the perioperative services space? And Amy, I'm going to send that question over to you to start with.
So I think one of the biggest challenges that we run into as far as sustainability is keeping our staff and having consistent staff to be able to sustain the processes. So one of the things that sometimes gets forgotten or kind of pushed to the side is retaining employees, because you need that consistent staff that is going to understand the process and be able to continue with the work that you're doing. And that's certainly one of the biggest challenges that we face and that I've faced in many other organizations as well.
Absolutely. Staff retention, right? And we're all still reeling from the impact that we've had, from the COVID pandemic. But, that's not a new topic, even with COVID. Staff retention in this area is very challenging. And we're going to circle back to some of these themes. So I'm curious, Dan, do you want to share from your perspective what some of the challenges uniquely that you've run into?
Yeah. I think I'm coming from emergency medicine. I'm newer to surgical and interventional services, and really in my role as CMO, I've started to have the opportunity to really do a deep dive with those teams and understand it on both the intrinsic bedside scale and then also the system scale. And really what strikes me is just the staggering complexity of that arena of our operations. It is extraordinary how many different processes, how many different teams, and how many different connections there are. And therefore, sustaining that level of complexity and designing within that framework and trying to make the work easier and yet meet the challenges of compliance is a constant challenge. Layer on top of that, as Amy pointed out, staff turnover and the need to bring new people into that system and introduce them to that complexity and how to navigate it efficiently means that this is a vibrant but complex arena that requires a lot of dedication from the team and from leaders to really help keep those systems aligned and running smoothly.
Absolutely, right. There are a few more complex places, maybe the emergency department.
I don't know. I think it may even beat the ER. I got to tell you.
Yeah. Maybe it feels somewhat straightforward, right?
That's right.
And so there's a lot to unpack in that. Before we move on to that, I did want to hear from Sean, and let's see what kind of themes we're starting to create. Sean, what's up? What are some of the things you've run into?
Yeah, thank you. So being here at the ISC, Allison, as you had said, one of the largest freestanding support centers in the country, as we know, we're in kind of a unique situation in that there's really nobody out there in the country and the world doing exactly what we're doing in terms of the services we're providing to as many customers and the complex surgeries that we're doing. So I tell this to other health systems that come and look here or have a call with us if they have questions about opening a facility like ours, that really we're kind of trailblazing as we go. We don't really have anyone to turn to for questions. So in terms of sustainability, it's been difficult for us in the 3.5 years that we've been open in maintaining sustainability, really when we're still trying to get our footing under us and really adapting to the new normal for Penn Medicine in this facility and the services that we're providing. We have come a long way. Some of the work we've done, again, when we opened, we took leaders and staff from multiple different entities within the Penn Medicine system, and they kind of got stationed down here, as well as some outside staffing and support. So a lot of different viewpoints were brought into one, and trying to mesh them together and create kind of a more standard approach to things is how we're now adjusting to that, and really trying to push that standards forward is something. It's been our challenge, but I think it's also the path to success, both for us and for anyone that's attempting to do this kind of offsite processing facility.
Yeah. Thank you, Sean. And again, a very unique example. It's hard when you don't have colleagues or others to look to, right? And to help you figure out how to tackle some of these challenges, which is a little bit why we're here today, right? Is how can we create some resourcing for the broader healthcare community in this discussion. I want to come back to this topic of complexity because I'm hearing it come through in all of your comments. And I'm curious, as you think about complexity in the space and what you've encountered, any specific examples that you'd like to share? Dan, do you have anything from your experience that you'd like to share? Dan, are you muted?
Sorry about that. Wouldn't let me unmute.
That's
Yeah, I think about the surgical and interventional services in two dimensions or domains. One would be the connected patient journey. Everything from a patient gets referred to some form of specialist or proceduralist, and how that provider determines that yes, a procedure is indicated, and therefore kicks off a procedure plan that's unique to that patient, and all the many steps that have to occur all the way up to that patient landing on a table in an operating room or a cath lab or something like that, and the recovery and all of those complexities. And then I also think about it in terms of the sheer complexity of what we do in the actual procedure in terms of the supplies and services that a team like Sean's is delivering, or the quality and safety that Amy's team is working on. And when we've looked at this, we've started to do a deeper dive into particularly that patient journey and trying to understand how do we make that connected, seamless, efficient, and reliable. And we find that it's a tremendous challenge because we have an employed group of providers and proceduralists, but we also work with a large group of affiliated providers and proceduralists that are not employed. And yet all of those factors have to come together synergistically and produce the same inputs to the system, if you will, so that we can reliably connect the patient to those services and achieve those procedural goals. So we've done a lot of work trying to just map out that journey, understand what are the specific steps associated with each of those phases. What does the perioperative surgical home look like? What does perioperative pre-procedure optimization look like? Who does that? Who's responsible for that? How do we determine then that the patient is ready on the day of surgery and communicate effectively with them? And as we map that out, we see more and more layers of different teams, and we're seeing opportunities to align those teams and consolidate some of those services. And we're really working on the relationship between us as a hospital-based operating room and supplying services to those proceduralists and those patients, and seeing them as customers, and reciprocally, they are supplying information that's essential to us being able to supply those services. So focusing on those supplier-customer relationships has helped us clarify how those teams intersect and where those gears mesh together.
I love that you brought up the topic of customer supplier relationships. You're speaking our language, Dan. We have there's so many relationships that you're managing in the perioperative space. And I'm intrigued because Sean, I'm thinking of you, and I'm thinking of the ISC, and that's been a very direct work effort, right? That's had to go on as you think about the design of the ISC. Can you share a little bit from your perspective about how you're thinking around those relationships?
Yeah, so as I said, Allison, so we are in, again, a unique situation in that we are servicing multiple different hospitals. So we have 6 distinct operating sites that we service. They're really fall under 2 of our main hospitals, with the Hospital University of Pennsylvania Hub and Pennsylvania Hospital. All that is contained within the Penn Medicine Health System. The multiple other hospitals exist that we don't service quite yet, including Lancaster General, where Amy's from. But we're all in communication and constant collaboration with them. So when we opened, again, we had essentially all of HUP's ORs and their cases and instruments coming to us, as well as Pennsylvania hospitals, and supplying them back to them. Even though we're in the same health system, it was really servicing two, and we call them customers, two distinct, unique customers with very unique demands and requests. So even though we're in the same health system, it was really essentially like dealing with two different customers. We've since, as I mentioned before, trying to standardize as much as we can. Obviously, with the trend in healthcare consolidation, there's been a tremendous amount of that within the Philadelphia region alone. Whereas these health systems keep acquiring additional hospitals and clinics and things like that. And I don't think that's going to change. So I think, speaking for Penn and other health systems, only going to grow. So when you have a center like the ISC, a centralized location to handle multiple hospitals, clinics within the same health system, it's really important to be able to standardize as much as possible. Because all of a sudden what you were doing within the walls of your hospital may have worked for years, despite the other partners, hospitals within that system, but it's not going to work when all of a sudden things are going off site and have to be handled on such a large scale. So we are really trying to drive that standardization to become as sustainable as possible and roll different initiatives out to these hospitals. It is challenging to do so when, again, a lot of hospitals have been doing things a certain way for a number of years. Staff kind of, believe what they're doing is correct. So we're slowly, carefully trying to work that standardization in, and we've had some good success over the past, I'd say, 2 years in doing so. But obviously, that's our biggest initiative going forward.
Yeah. That key of, how do you create that standardization from your perspective, right? Because that's going to help your operations flow effectively and smoothly, and hopefully get them what they need. At the same time, again, that complexity of that environment and the number and variety of people that you're servicing, right? We have RNs and nursing staff. You've got surgical technicians, we've got surgeons of a whole variety, right? In terms of, particularly, I think of the complexity within Penn Medicine, and, it's every specialist, right, that's out there. And so I know that's not easy to do. Can you share maybe some of the challenges that you've run up against with that?
So an example, again, when we're meeting with other clients, we tell them, so again, there are two main hospital partners, right? A very common surgery is a thyroid surgery. So there's a thyroid tray. So Pennsylvania Hospital has their own thyroid tray, and HUP has their own thyroid tray as well. The instruments and the items within those trays themselves are very different, and they are not interchangeable, right? So there might be a day that we need a certain number of those sets for HUP that we don't have enough of, or we're gonna have to get creative in finding, working around those inventory constraints. Whereas we have a cachet of the same tray from Pennsylvania Hospital essentially sitting here on our shelf, but it's not able to be used because it's not standard. Even though the same surgeon might be operating at both locations, they, want and need what they have at that specific site. So really trying to take that step back and standardize. So instead of calling it a HUP or pH specific tray, can we call it something like a Penn Medicine thyroid tray? We successfully have done this with 2 smaller sets. In January, we rolled out 2 specific sets to do this. We call them UPHS sets. So they are stored here at the ISC. It's the same exact set used at both locations. And it's been a great success so far in that we have enough of them. There's not inventory constraints, and we were able to save a significant amount of capital when purchasing these instruments. So that's essentially really what we want to do to be able to roll that out. Worked at multiple different health systems, and trying to align that work down to the level of detail is extremely difficult. It takes a lot of buy-in from the staff levels, senior leadership, to make sure that the surgeons, the proceduralists are on board, the staff is on board. But ultimately, it's what we think is the best path forward, and something that we're really striving towards.
Yeah, I appreciate that engagement piece, right? Like, how do we connect with the providers and really engage them in that design? Because again, back to sustainability, how is it going to stick, right? And how are we going to be compliant if we actually don't win the hearts and minds? Dan, I see you leaning in.
Yeah, I think Sean makes such an important point there, and I have had similar experiences, and I think it's caused me to reflect on the fact that we're a quirky industry. In healthcare, we're not afraid of risk, not afraid of complexity, very driven towards the individual outcome. And yet we also struggle with exactly what Sean is highlighting in those trays, in the concept of sustainable design, in the concept of systems engineering. And on the one hand, I get it. I'm a provider and you're doing a procedure and you want that familiarity and you want the tools that you need to do that procedure. Unfortunately, we spend a tremendous amount of time bending over backwards or sideways or through hoops to try and accommodate those individualistic needs at the cost of sustainability, at the cost of efficiency. And somehow we have to bridge the cultural chasm there to bring the entire team, the bedside team, the proceduralists, and beyond into the design phase of saying, what if we design this so that it works better for you? What are the most essential things? What are the less essential things? How can we collaborate to create some consistency here? Because in the end, that's what people really yearn for, particularly in patient care arenas. But to Sean's point, it's really hard to get surgeons at different sites to agree on the same retractor sets. And it's in a space where we really have to focus on that human-centered design piece and engaging people and understanding what the implications of those different choices are. Not in a punitive way, not to say, no, you can't have that, but to say, here's what we're trying to achieve and here's why. And more now, I am noticing that clinicians are willing to enter that conversation because they're feeling bent and overtaxed and feeling the same pressures that all of us are feeling on the operational side. And so now I see clinicians that heretofore might have been more resistant and teams that might have been more resistant saying, okay, what can we do? And if you can make that next shift better, if you can make that next procedure go smoothly for me, I'm willing to work collaboratively to start to do some design work in that space. And I think that's such an opportunity for us to start to introduce more of those design elements into the sustainability of these things.
Yeah, the time is right. You know, and we're seeing more and more of that systems understanding idea and how the interdependencies are. And so we've got to lean into that. Amy, I'm anxious to hear your thoughts because I know you've got them around this particular topic from your perspective.
Yeah, I was just thinking that not only are we sacrificing sustainability, but we're sacrificing the patients as well, because there are so many downstream effects to having all of this variation. Like, for example, we have patient delays, and we can cause issues with our sterile instrument trays that can then potentially reach the patient. We're definitely increasing the risk when we don't have that smooth process getting us to the patient. So it's certainly an issue that we've run into as well. In fact, there were well over 100 trays that we decommissioned very recently because there was so much variation, and there were ones that were just no longer being used. And all of those extra instruments, all of those extra processes can cause confusion, and it causes lots of room for error. So we have to go back to what are we all here for and what is the most important thing, and that is the safety of our patients. And I think that you'll find that a lot more people are willing to compromise or willing to meet in the middle when that issue is brought forward, because that is truly what we're all here for. We want to keep our patients safe. We want to do right by our patients, and maybe having all of these different individualized things is not the way to get that done.
And, you know, I know that challenge of, you know, how do you balance the efficiency in the OR, people's time, because we're dealing with schedules that are outside even of the facility's control. How are we thinking about the patient need, the infection prevention and safety elements that need to go on, the regulatory requirements, you know, all the multiple inputs, right, that are coming in from many places, from the emergency department and traumas. And I mean, it's such a challenging environment to balance all those balls, if you will, and juggle them all successfully. And Amy, I know that in your unique role, can you maybe share a little bit of an example with us around how, from the infection prevention side, you help to sort of bring in that regulatory patient safety component in a way that's successful in meeting all those other aspects of need.
Yeah, one of the ways that we do that is just by facilitating conversations, because all of these areas are very complex in and of themselves, and they have a lot of inputs just in their own separate area. And it's easy to get lost in that and forget about what is going on in the other areas. So in infection prevention, what we like to do is bring light to all of the other areas that are involved in the care of the patient. And that crosses the entire perioperative period, from the very first consultation with the surgeon until weeks, even months after the surgical procedure happens. So we facilitate those conversations among those groups. We make the information from one group to another visible, and we make sure that everybody's aware of what are the goals of the other areas and what do they need from your area. You need to facilitate that peer-to-peer conversation. What does the OR need from sterile processing? What does the office need from the hospital? There are so many different inputs. You have to have communication. That's the number one priority, and that's what we do.
Yeah, and that interdisciplinary piece of it, I think, is really critical. You know, how we bring the expertise and the voice from, you know, again, all the different areas together. And, you know, unfortunately, in a lot of history, areas like sterile processing, for example, or the materials management side, or your support, like infection prevention, some of those things aren't always upfront in the conversation about how we're going to design a particular service line or a value stream within the perioperative space. And so it's exciting to think about, like, how do we start to frame those conversations differently? And I know, Dan, you and your team are venturing right into some major surgical services improvement. So can you share a little bit about how you're thinking about that?
Yeah, we're focusing again on that patient journey piece, but primarily to understand what the procedure plan is and how we layer nuance into that procedure plan from the moment the proceduralist says, this is the procedure we're going to need to do, these are the risks associated with it, and this is my plan to prepare the patient for the procedure, and this is what I'll need during the case, all the way through the different layers of anesthesia reviewing that case and surgical optimization prior to the procedure. And then in the case itself, we're finding, you know, as we start to do some failure mode effects analysis on things like case cancellations within 24 hours of the case, we're trying to work upstream from that and say, where was that defect entered into the process that led to a cancellation right before? Because we know those cancellations have a huge impact on patient safety, on patient experience, on cost, on quality, on lots of things. And as we start to look at the math there and trace those upstream, we see some common denominators. Certainly you have your insurance authorization, and that's its own black box of processes. But even beyond that, you have things around optimization and medication management in the perioperative period, and sometimes down to the case trays. We have, you know, one proceduralist here, an orthopedist, that often will order as many as 30 case trays for his case and use 2 or 3. That's horribly inefficient and ineffective. And so trying to align all of those things as efficiently as possible and trying to start to redesign those processes and figure out what is the signal that is unifying through that journey that each team is looking to understand their piece and their role, and trying to tie that back to some elements. We use Epic in the Snapboard case creation process to try and better orchestrate that. As we've done that work, we've discovered one of the problems is that nobody owns that. Everybody has a piece to it, but nobody owns it. And therefore, we're having to create some governance and some structure around, okay, let's look at those relationships of who's using this information and how they're using it, start to create some structure there, and start to create some expectations. again, with an understanding of not just being dictatorial, but to try and engage people in understanding why it's so essential that we interact and collaborate in that space effectively so that we land the patient on the day of the procedure with all the things they need in place to be successful.
And, again, all those interdependencies. And you mentioned a failure modes effects analysis, right? It's one of many performance improvement tools that exist out there, but thinking about focusing in on where like case cancellations are failing us and how do we really focus in on that defect component, that deep process orientation is exciting to hear about. What kind of engagement are you getting on that work within your team? I'm sure those can be rigorous tools.
Yeah, well, the challenge is, like many health institutions, we struggle with data. We all are empiric and data driven, and yet access to data and even at the team level, data literacy is a challenge. And so trying to get that data, I'm working with an analyst, we're collaborating. And so we did an analysis in the first 8 weeks of the year. We had 207 case cancellations. And so now we're looking through those cases and classifying them and creating a Pareto of what those different causes were. But a lot of that remains somewhat manual, and we're trying to build out the data model to be more specific and explicit in this area and tie that back to how we're creating the data through Epic and other things. We started with just literal paper lists and paper Pareto tools, but we're now trying to create more robust dashboards. It's frustrating how hard that is, how much time it takes. It feels like, as sophisticated as we are as an industry, we should be much, much better at that than we are. And yet that's the curve and the spot on the curve where we are. And it is encouraging that as you come to these conversations and we're trying to get alignment and buy-in and have these conversations around suppliers and customers and engagement, if you come to the table with that data and you can tell them more about the process and more about their practice or more about these types of procedures, then you quickly gain traction in that conversation. And you can take some of the personalities, some of the just personal discretion and preferences out of it, because the great news is everybody, top to bottom, I think, in healthcare tends to be fairly data driven. We understand that it's a complex space. We understand that it's a high risk space, and we need to really hold ourselves accountable to reliable standard outcomes. And the data paints that picture for us. And so the more we can use that in a positive way to bring people to the table and engage them in the conversation, the more we open that door to, now what can we design within this framework, within these constraints, within these problems? What are the opportunities to evolve these processes to something that's going to feel more sustainable and make your next shift and your next procedure better, easier, more fun, bring some more joy back into it, because that's really what we want. We're staggering under the load of complexity, and we really want to design a process that feels like it runs and like you actually get an element of joy to be a part of it. And too often we feel like we're just banging our head into the wall again and again.
Yeah, I love you bringing joy back into this conversation because, we're here to take care of patients and to do what we love to do. And so, how do we find ways of continuing to think about our work? So we focus there. I'm hearing to this theme a little bit emerging around governance, data, feedback, right, on performance and how that layers into what we do. And Sean, I'm thinking a bit about, some of your experience at the ISC in terms of governance and structure and how you provide feedback, because again, you're not right there in the hospital, you're not down the hall. You've got to think a little differently about how you're reaching out and connecting. So can you talk a little bit about how you've approached that topic of governance, ongoing performance improvement, how you're building those systems?
Yeah, so I think I'll go touch briefly on two kind of high level things that we've done. So we, much like Dan said, we struggle in collecting data where we all want to work off of it. We want to see as much as we can so we can collect that and share it, the good data, the bad data, and we do that to the best of our ability. One area where we really struggled and before the IC even opened, and I'm sure this is fairly common in all health systems, but getting quality reporting back to us and meaningful quality reporting. So if there's an issue with an instrument set or a supply, how does that feedback reach essentially the right team, right? The right leadership structure. So it's much easier when it's contained on site. If there's an issue in a room, you're right there. CPD is typically right down the steps, right next door. It doesn't take very much to get that information there. But here, we're miles away. We're isolated. So how does that feedback reach us? And our instrument tracking software has a module in there that you can provide feedback. It's tedious to use. It doesn't give us meaningful feedback, we realized. And then Penn Medicine as a whole has a safety reporting system that's extremely cumbersome in the moment. A lot of fields to enter that doesn't seem quite right for something as simple as a set contamination or an issue. So what we actually developed was we printed out a unique QR code and fixed it to a badge buddy. So essentially behind everyone's ID badge, they have an additional card that has a QR code on there. When they scan that with their phone, they can use a personal phone or a work phone. It brings them to a very simplified form through actually one of our IS applications that was already in use for IS tickets. And I think there's like 5 or 6 fields that they fill out that gives us all the pertinent information we need. I've used it many times on site and, providing shoulder education. It's very easy to use, allows us to get the information that we need, as well as attach pictures, which is a downside of all of that, to go with that data. So we've seen a significant uptick in the amount of quality being reported to this. And then in turn, we can look internally, provide that feedback to the individual that may have had the issue, whether it's a set construction issue or a contamination, provide that with the picture to them, and then look at our bigger process as a whole. If we start to see patterns and trends, we track these issues down to the entity, to the technician, to the service line to see, are we seeing patterns? Do we need to target in services, specific sets and things like that? So we've had great success in that. Obviously, we want the staff to use it more. And one of the big things that came out of that is we're able to compile monthly statistics. We call it our report card. So essentially, we look at the total number of sets that we process here in a month, and then all the issues that we've collected in terms of that QR code, that safety net reporting, as well as internal audits, and do simple division and give ourselves a score. And we communicate that really to all the audiences that want it. We presented at OR Exec Committee a few weeks ago, and that number is what we're receiving, right? So if surgeons or staff are saying, we're having a lot more issues in this, we try and graciously say, well, let us know. We don't know what we don't know. So if you're not feeling our 98 or 99% success rate, you think it's much lower than that, please give us that feedback so that we can, target and adjust it. We have had, again, really good feedback through those tools and through that specific tool that we've been able to focus on specific areas, change some processes here at the ISC, re-educate staff, and seeing some good success. So it's just one example of something that gives us data that we're able to drive forward, in the complex environment that we're in.
And Sean, I love that example of many different things that you're putting in place that you described, because it's creative, it's oriented to the specific needs in the perioperative environment, because you ran into, right, you were testing different ideas and concepts, and testing those ideas, you're running up against roadblocks, but how do we keep getting the customer feedback drawn into that? And we know voice of customer and performance improvement, lean thinking, any sort of process improvement design is just essential here. And they were telling you what's working, what's not. So how do we find a way to get that feedback? And you've taken it into the feedback loop, and then you have mechanisms to routinely review, right? Do we know that we're winning or losing? And how do we know that? And how do we continue to use that to drive the next step of improvement? And so just some really good examples. And I have a feeling that some folks that are on this webinar are making notations of a QR code and how that and how you've managed to make that work with the OR team. So thank you for that. One reminder I just want to throw out that we do have a live chat. So, and I see some activity going on in the chat. We encourage you, please, if you have thoughts, comments, or questions, please use our chat. You're seeing some things there that are dovetailing off of our conversation. I want to swing back, because there's so much in here we can talk about. I want to swing back to this topic of staffing. And I understand that, we're all dealing with staffing challenges in our respective areas and reacting to it. But in some ways, we're all sort of so supportive right, departments that I see here around, or leaders in areas that are facilitating change. So how are you thinking about the piece around turnover, right? And how do we onboard appropriately? And how are we keeping up with the change? So many leaders I talk to say, but we're back to this topic again. We keep recycling on the same problem over and over again. So, Amy, any thoughts that you have to share around your experience with that?
I think one of the most important things that you have to keep in mind is that while you may be understaffed right now, you may need people up and running yesterday, but you still need to take the time to onboard people appropriately, even if it keeps you in that crisis mode for a little bit longer. Because if you rush people out of their orientation period so that you can get a body on the floor, they aren't going to feel supported. They're not going to do the quality level of work that you need them to do. And they might leave and you might be back in the same boat tomorrow. So you have to take that extra time to do quality onboarding for your staff so that you can retain them, and that when you do get somebody on the floor working independently, they are putting out the product that you want them to put out.
It's essential, right, that we train our teams effectively, and we all know the pressure point. But how do we make that a successful experience? This is a big enough topic. I'm going to go around and I want to hear different perspectives. So Dan, what are some of your thoughts as you're thinking from your viewpoint into this?
I think we're at an interesting inflection point. And as an industry, historically, healthcare is about humans caring for humans. And that's part of the beauty of it and the magic of it, and the very essence and heart of what we do. And yet we also use humans fairly inefficiently in our industry. And there's huge opportunities to figure out better ways to leverage skill that we absolutely need and eliminate drudgery, which we absolutely have. And so how do we find those opportunities? And in so doing, how do we engage our teams in that work and in the sense of team and filling an important role that's clearly defined on a team? And that's how we're approaching both recruiting and retention, is trying to understand we have to be competitive in the marketplace in terms of benefits and wages, obviously, and yet it has to go beyond that. People in this industry are, in a lovely way, dedicated to mission, but you also want to be a part of an organization that feels like it values you and like you can be really productive at the top of your game and top of your license in what you're doing. And too often we have thrown humans at problems just as a means of getting tasks done. And so we have to eliminate some of that drudgery and let people really focus on the really high-end work that they do, either the cognitive expertise they have, the technical expertise they have, or just the human compassion, the handholding, the fundamental pieces that make a healthcare journey really beautiful and meaningful. And so the more we can focus on that and eliminating some of the just plain tasks and start to leverage better tools. Sean again brought up a great point about a safety reporting system. They're rarely designed for the user experience, right? They're designed to capture the data that you need in order to do all that safety reporting. But why does it have to be designed that way? Why does it have to be that way, right? Sean's team came up with a better QR-based system that's much faster and easier and already getting better results. Our billing systems, our EHRs were largely built for billing, not for clinical care. We have to continue to push back against that and say, no, there's a better way. We can design this to be better and more intuitive and more aligned with the work that we do and the work that we know how to do.
Absolutely. And you've got some amens going on in the chat. This is resonating because, when we think from our standpoint about principled-based design, right? So this is one of the things value capture really leans into, and it comes from these Shingo principles and concepts and Toyota production system and that really essence and root of lean. It really comes back to the respect for the individual and the human, right, that's involved in this. And that is such a critical piece that we don't often spend enough time, I think, focusing on in healthcare. And we need to focus on our patient. We absolutely do. But at the same time, we also need to be focusing on our caregivers and how they're interfacing, right, with the system. And so how do we make sure that we are designing systems of work that have the principles of respecting for individuals at the core? And if we do that, it's going to lead us in the right way, right? Because then our caregivers can care for our people. They can care for the patients, they can care for the community, and they feel valued in that. So thank you, Dan, for bringing us back to that. Sean, give us some of your thoughts, because you're dealing, I mean, you deal with a challenging area, right? That has high turnover, staff that often can feel undervalued and underappreciated for what they do, and they are absolutely critical to the safe care that we provide. So share with us what you're thinking here.
Yeah, so again, in a unique situation, right? Historically, sterile processing staff, as well as our, the other half of our operation is case picking. So that materials team, we call them material service partners. Usually underappreciated, right? Kind of behind the scenes. We actually had a surgeon just this week refer to us in an email, kind of giving us credit, saying, we're like the field goal kickers, the football kickers, right? You're loved when everything goes right, but as soon as that one mistake happens, it's an instant blame and not a lot of support on the sidelines there. So we feel that, and then add another element of being remote and offsite, removed from the hospitals. Whereas there may be a few advantages. You're not going to have a nurse manager or a surgeon coming in and catching someone in the hallway or coming into the department directly. We are removed from that, so we try and keep everyone as engaged as possible to what's going on, in the main kind of health where the hospital is situated, right? All the events going on there, and try and go back to the big picture that there is a patient at the end of this line, a surgery that's very important. The other thing that try and keep in mind is that we have, specifically with our case picking team, the base level position there. It's an entry level position that a lot of our staff comes right out of high school. All that's required is a high school degree or a GED, and it's a tedious job to pick cases all day. That's all they're really doing for a good 7.5 hours of their day is picking cases. So putting supplies and instrument sets in a case cart. So that redundancy and that 5 days a week of doing that, how can we keep people refreshed and for hitting our productivity numbers and our goals? And I think the uniqueness in the workforce is changing, right? Specifically with a lot of those younger workers. I'm not terribly removed from the staff level, so I kind of know and I've experienced firsthand what these trends are and things like that. So I try and communicate that, that change to some of our more senior staff who might be used to a different type of work environment, a different type of, the commitment to a sole employer or health system it's changing. It's not really there anymore. So how can we engage that and, anticipate that people might not be as committed to us, and that we are an entry level role here. We expect growth, we promote growth. So how can we get creative, making sure that we have the staff that we need at all times to do so. So again, it's been a challenge, as is everything, but something that we've reflected on and trying to, always listen to the staff, include them in all decisions here, get their feedback and make that meaningful. I've been in multiple departments where, you feel like you're screaming into a void and nothing's being really reflected on. We try not to do that here. At least I try not to. I'll talk to all the team members, spend a lot of time with them back on the shop floor, making sure that I understand what they're going through, and what needs to be done to essentially make their work better. And then, again, at the end of the line is a patient surgery, making sure that happens on time and with the items that are needed.
Yeah. Thank you for that, Sean. And you're hitting on some important themes around the changing workforce and the fact that we know, people aren't necessarily going to stay for 25 to 40 years in the same place, right? We know that there's a movement happening there, and how we support you through your growth. I love that frame of reference too. And healthcare is a beautiful place to be for ongoing professional development, right? If we can figure out how to build that into systems and connect that, there's places for people to go. They can enter our system and they can enter as someone picking a case or an EVS staff member, and they can work their way up through, and they can learn and they can train. And so how do we embrace that idea, right, of continuing to fuel our workforce from within through doing that development? So, and again, that's just one of the points you were making. So I appreciate that. So I'm watching our time a bit, and we're getting closer to the hour. Go figure. We've got lots to share here. I'm monitoring for questions, and at this point, I don't see anything that's uniquely come through that maybe we haven't touched on. So what I'm going to do is ask you a question, because I'm curious to hear about, as you think about your next effort in Periop, and you all have something going on, I know you do. What are you thinking differently about? What's the approach, the unique approach, maybe a change you want to make in terms of how you approach the work with the teams, based on what some of these challenges we've even talked about today, or that you've reflected on with your experience. And so, Amy, anything you want to share?
One of the things that it's really been driven home for me recently is just making sure that everybody is keeping their number one focus in mind, which is the patient. And are we sharing the information with the teams that shows what their impact is on our patients? Mm-hmm. And even going back to staff retention, if staff know that they will receive quality care from their organization and their loved ones will receive quality care from their organization, it's really going to give them passion for their work. It's going to give them dedication, and it's going to give them loyalty to the organization. So what are we sharing with them? Do they know how much of an impact they make? And do they know what all of their work does to improve that quality of care to the patients that we serve every day? That's something in infection prevention we can help to display that information. We can show that this work that you're doing is driving down these infection numbers for our patients, or this is causing improvement in the OR from the work that you're doing in sterile processing. And because of that, the OR is now a safer place for those coming in to have surgery. So how can we make that information more visible to the staff? How can we tie their work back to this impact to our patients? And how can we make the work of the other teams more visible so that we can improve that line of communication?
I love that, right? Why does my work matter, and make it real and connected to them? So in just under a minute, Dan, any thoughts?
The job of a chief medical officer is broad and sometimes bizarre, but the best parts of my day are when I get to stand at the intersection of systems engineering and human-centered design and really work with teams thinking about the way they do their work, why they do their work, and how we can connect those different pieces together. As a system, we have 8 hospitals, and we're really trying to challenge and understand how to work better as a system, how to distribute services across that, how to create governance so that our leaders can have effective and timely decision-making, and so we can understand how to serve our communities better by distributing those services effectively. To be honest, we're not great at that. We have a lot to learn, and there's a lot of rich conversations to be had there. So we're doing that work sort of at the system level in parallel with all the things I was talking about in terms of just trying to orchestrate and marshal the many different aspects that go into SIS. It's going to be an ongoing journey, but with every day and every conversation we have with the teams, it's pretty inspiring. And what's really exciting is seeing them get inspired. Like, oh, somebody's really paying attention. Somebody wants to make this work better. Great, I have some ideas. And that's really the spark of innovation and enthusiasm that keeps you going.
That's fantastic. And we wish you all the best on that journey, right? And because it's a journey. Sean, any thoughts from your perspective?
Yeah, so the 2 big things I'd say are communication and collaboration. And I know that's kind of a bland, generic answer, but with a facility like ours, it's more important than really ever, right? Again, when we are doing what we're doing here and being off-site, everything needs to work perfectly for the things to go as planned. Again, you lose the comfort and ability to run down a flight of steps and get a set or a supply if needed. If it's not there, it's going to take time to get onto the table. And the accuracy with what we're able to do so relies on so many people and so many steps along the way. So it wasn't always that way, and there's still days that we struggle with it. So I always, try and instruct the teams that communication is absolutely critical to our our mission here at the ISC and supplying everything that's needed. And as well as providing that feedback to the hospitals as well. Again, a simple phone call historically down the CPD might have been that's all it's needed, but we need a lot more information here. And it's something that, a lot of people aren't used to, but without that, things fail, and trying to make sure that with a process driven environment that those are honed in on.
Thank you for that, Sean. And thank you all for just some really good perspective sharing as we wrap up today. I'm going to share just a couple things on my screen here as we wrap up and give you some resources to reference. As Value Capture is working with many, many different clients right across the country, and we've got things that we've talked about here. I just want to reinforce them. When we think about perioperative services and assessing, right, what is actually happening in your current work streams. And we talked about things today. We talked about data. We talked about observation and bringing in the right team members and really looking at a value stream. How do you think across the continuum? How do you make sure you're considering sterile processing along with your OR staff and your patient-centered medical home and PACU and all the components, inpatient services, your infection prevention needs, and how are we meeting those? And so it is a very complex environment. So getting into that full value stream look and making sure you're pulling the right people in, and then using that to help identify and prioritize. We lean heavily on this concept of the 3 integrated work systems: improvement, work, and management systems working together. And so when we think sustainability and we help clients with sustainability, this intersection of these 3 systems together is critical. How do we design the work from that systems viewpoint, from our customers' standpoint and perspective? Are we following good principle-based thinking around the design of the work so it's achieving the result and outcome that we hope to see? How are we managing to the standards we put in place and ensuring that focus on customer orientation? Sean talked a lot about that today too. How are we connecting around the customer and bringing that information back to the front line? And then of course things go wrong because we live in the real world. And so when things go wrong, how do we know about them? How are we sensing those improvements? How are we responding real time and teaching our people how to improve effectively? That for us is the magic of sustainability. When you start to build and design operating systems that emphasize all 3 aspects of this. And so that's just a little nugget that we would leave you with from our perspective as well. I know we're out of time. It's been a great, rich conversation. We want to, of course, leave you with resources on our end so you can see with Value Capture. We have trusted advisory services that go all the way through preparing you through an assessment, taking you through the transformative work, doing problem solving, executive coaching. We have lots of learning and development opportunities that are out there, and we invite you to explore our website to learn about those. And then we have plenty of resources like this webinar here, podcast, case studies, et cetera, to learn from. If you want to keep this conversation going, please reach out. You see my name and information here. Also, Ken Siegel, who's joined us behind the scenes today, is our Chief Relationship Officer. And of course, you can also go to our website, click on any of those areas to learn more, follow us on LinkedIn. Many ways to reach out and connect with us, and we invite you to do so because we'd love to continue this conversation with you. We do care about what you think of this experience. So you're going to receive a link as soon as you log off to provide an evaluation of this particular webinar, as well as look for an email hitting your inbox to anyone that registered. And then here are our folks again, and this is the slide I'll leave you on. And you see that we have contact information down below each one of their profiles if you want to reach out and connect. I know any of these individuals would love to continue that discussion with you as well. Thank you all so much. We appreciate it. We appreciate your time, and we'll look forward to connecting with you soon.
Thanks very much.